Thank you all for joining us today. My name is Rebecca Kiesling, and I'm Managing Director at the Benjamin Rush Institute. If you are not familiar with the Benjamin Rush Institute, BRI is a national nonprofit who reaches out to medical students from across the country and some international chapters as well. We educate medical students on the free market healthcare alternatives that they just aren't learning about in medical school. Medical schools are primarily funded by big business, big pharma, big government. And with that, their education is guided by those principles. There's a lot more to their education that they need to know before reality hits. And that's where we come in. We don't provide that. We're not the educators. We don't drive that policy, but we bring in wonderful people, experts in their fields, physicians, policy experts, and a whole bunch of wonderful other practitioners that can speak to these and really provide a well-rounded education to medical students that they need so that they can influence their profession, whether that is advocating for their profession or driving what their next decisions are going to be. We started this virtual event series in response to the pandemic a couple of years ago now, and it's been wonderful to be able to reach out to not only our medical students, and I'm thrilled that we have a couple of, even though they're not in classes right now because of the break, a couple of chapters are joining us today virtually, but also our physician supporters and other network of supporters are joining us. This has been wonderful to continue that education, not only to our medical students. I am thrilled about what we're talking about today. It is something that I have had to really get smarter about in the past couple of months. It's not a topic that I necessarily know a lot about, much to the chagrin of one of my daughters who is going to be attending pharmacy school. But I think it is something that as someone who receives these benefits, I need to know more about, and as someone who talks to medical students about how this is going to impact them, I definitely need to know more about. We talk about PBMs, we talk pharmacy benefit managers, so much in how that influences healthcare. You probably have read about this a lot in the news, and you probably, as medical students, you hear about how you have to interact with pharmacies and your pharmacists. But how is that impacting healthcare, and how is that going to impact you in your decisions? In the news recently has been brand drug price increases that went into effect this year. We talk a lot about transparency and pricing. And this is something that impacts us across the board in our healthcare. I came across this person that we're going to speak to today on LinkedIn. And I have to tell you what his LinkedIn profile says, because if this isn't perfect for somebody we need to talk to, I don't know what is. His LinkedIn profile says, obsessive about the prescription drug supply chain and pharmacy policy, advocate for open access, transparency, competitive markets, and patient-centered care. That's pretty much the perfect person to be talking to us today. Antonio Ciaccia is the CEO of 46 Brooklyn Research and president of 3 Axis Advisors. Born and raised in pharmacy, Antonio has been crawling around pharmacies his entire life. I like that. After 3 years as a pharmacy technician and 2 years of pre-pharmacy curriculum, Antonio diverted course, graduating from the Ohio State University with dual degrees in communications and political science before moving into association management. So my guess is he's still living off of a high from the Rose Bowl game. We'll get into that. Thinking that pharmacy would be behind him, he made his way back to pharmacy, heading up government affairs for Ohio Pharmacists Association, which is a trade association, and you can look this up. They have a really strong record of advocating for drug pricing transparency, and they continue to do so. After years of studying pharmacy and that marketplace, he became even more perplexed about drug costs spiking while payouts to pharmacies were declining. Knowing something was being lost somewhere in the middle, Antonio has spent years working to crack the drug pricing code and pull the rug out from what he believes is one of the most dysfunctional marketplaces in the world. I have read and heard testimony he's given on both the state and national level. I have read a lot of what his organizations have done, and he's incredibly smart, and you're going to get a ton out of what he's talking about today. Wherever you are watching this, whether it's on Zoom, on Facebook, or in one of the chapters, please ask questions, because we're going to take those at the end, much like our other webinars. And we'll make that a little bit more interactive. So I'm going to turn this over. You're not here to talk to me. I'm going to turn this over to Antonio, and we'll come back later.
Thank you so much, Rebecca. Appreciate the kind introduction. Great to be with you all today. And very excited to talk about the dorky world of prescription drug pricing. I'm going to, I do have a slide deck. I promise it won't be too boring, and hopefully you find it informative, and we can address any questions you might have about this weird and complicated industry after the show. So as Rebecca mentioned, I was with the Ohio Pharmacists Association for about a decade. I got to know a little bit more about the complicated world of prescription drug pricing, and specifically pharmacy benefit managers, or PBMs. Most people have never heard of them. From a pharmacy perspective, think of pharmacies and PBMs as kind of Hatfields and McCoys. Ultimately, pharmacies, whether right or wrong, think that they should be paid more for what they do. PBMs, rightly or wrongly, believe that they should pay much less for the drugs and the services. Regardless of who's right, who's wrong, obviously you have an understanding of where that frictious relationship can at least stem from. Complaints from Ohio pharmacies intrigued me about how PBMs compensate pharmacies. When a pharmacy would dispense a prescription to a patient, it was, as many pharmacists would tell me, is basically the equivalent of pulling the lever at a slot machine. You had no idea if you were about to lose money, you were about to make money, you were about to break even, or you were about to get absolutely throttled in a huge underpayment, or get filthy rich off of a massive overpayment. The pharmacies had little control over that dynamic, but I was intrigued at how essentially the entire compensation model in pharmacy was, as pharmacies kind of framed it, playing at a casino. Years of learning and digging into how drug prices were set in the state of Ohio, specifically through our Medicaid program, and working with local investigative journalists at the Columbus Dispatch, led to an uncovering of hundreds of millions of dollars in hidden drug costs, and eventually a nationwide reckoning for drug pricing reform, and we'll get into that later. I launched 46 Brooklyn Research with a colleague of mine named Eric Packman, who's running a chain of small pharmacies in Ohio and Indiana at the time. And what we found was that as people were complaining about the cost of prescription drugs, very few people actually understood the sausage-making process of how cost is essentially created. We found there was a lot of publicly available data that could be utilized to help piece together how that sausage-making process was working. So we took a lot of publicly available data sets from CMS and other sources and published them online using cool dashboards and innovative tools, so that a layperson who may not understand some of the fundamentals of prescription drug pricing might be able to better access the true nature of how drug pricing works. We were bombarded when we launched in August of 2018. We did not anticipate the interest in, nerdy Excel sheets. And we were inundated so much so that we decided to launch a consulting firm. Certainly never thought I'd be a consultant by any stretch. But we felt there was a big unmet need in the marketplace, where many people, whether patients, payers, governments, et cetera, needed better insights into how the drug channel operated, and wanted to work with us to help solve the riddles that they were seeking to answer. Our clients today at 3Axis Advisors include Medicaid fraud control units, government agencies, provider groups. We do some work for a number of pharmacy groups, but also other provider groups, including the American Pharmacists Association, American Pharmacy Cooperative. I still help out my good friends at the Ohio Pharmacists Association as well. We do work for research firms, technology companies, law firms, investment analysts, employers, benefit consultants, and private foundations. So let's start with the very beginning of the issue, which is, what is the price of a medication? That depends. What price are we talking about? Because the drug flows through a number of layers in its actual physical distribution process, and also flows through a number of monetary layers when it comes to the compensation for the product, that means is that the idea of what a drug's price is can be very different depending on what stage of the drug distribution process you're talking about, and how you want to quantify price using a litany of the different pricing benchmarks that are available in the marketplace. What I typically say is all these different acronyms here are different ways that you can quantify price at various stages in that distribution and payment process. What it also means is that anytime you have more than one price, you have no such thing as an objective price. And so what that also means is that drug prices are hidden. They are set within proprietary contracts, not necessarily in an efficient marketplace. We'll get to what I mean by that here in a little bit. Contracts aren't inherently bad. Of course, they're two willing participants getting together to ultimately negotiate for a certain good or service based upon a particular agreed upon price. But when we talk about, again, price, anytime that they are subject to a quote negotiation, that price is highly variable. And that variability means that pricing in the drug context is heavily prone to manipulation by those who are either charging or invoicing for those medications in the first place. That's where PBMs came in. Decades ago, as more and more medicines entered the marketplace, and as prescription drug costs grew, plan sponsors, meaning employers or government programs that were paying for those drugs on behalf of beneficiaries, were looking for new ways to hold spending accountable. They couldn't just issue a blank check to the pharmacies, wholesalers, and drug makers who were ultimately responsible for what that itemized receipt was that people expected to pay, that people expected them to pay. So PBMs were brought in to act as a necessary friction against drug makers, wholesalers, and pharmacies, and other members of the drug supply chain. They were hired to work on behalf of those payers to ultimately achieve that equilibrium point of what a fair price should be for a medication. However, over time, as PBMs work to control that end of the supply chain, again, those drug makers, wholesalers, and pharmacies, the PBMs started to develop business interests in the very marketplace that they were hired to control. Today, when you think of a PBM, you may think of them as a middleman that facilitates the transaction between an insurance company and a pharmacy, or a drug maker and an insurance company. But what they also are now they own their own mail order pharmacies. They own their own retail pharmacies. They make money off of the list prices of medications. So while they were hired to control the prices of medications, now as dispensers, now as those who profit off of the list prices of medications, their incentives have become totally distorted and have maneuvered away from their origin, which was to act as somebody who was working to solely control the price of medications. Today, PBMs advertise that they are the only entity working to control the cost of prescription drugs, but the data that we've analyzed and others have analyzed show that PBM profits that are generated off of prescription drug transactions heavily distorts their incentives to control drug spending for their clients. So let's go back to the price. These are some pricing trends that we've seen on prescription drugs over the last few years. So prior to 2021, the number of annual drug price increases, we're talking about list prices here, have been in an annual decline since 2015. So the number of price increases over the course of a year have actually been going down over the last, or from 2015 to 2020. However, in 2021, we saw a change in that trajectory. more drugs went up in price than in years past. With 1,260 list price increases on brand name drugs, 2021 had the highest number of list price hikes since 2018. So far in 2022, this was just revealed, we put out a dashboard earlier this week. We already saw 460 brand drug list price increases on January 1st alone. Now, for those of you that look at January and say, oh my goodness, these drug makers are raising the prices, what are we going to do? Just know that in general, January is when the most number of price increases occur on brand name drugs. So while we're seeing a lot of price increases right out of the gate, do not expect that will be a continued trend through the months of February through December. So we tend to see a lion's share of all the price increases for the year happen within the first few weeks of the year. So while the number of increases has changed its trajectory from its downward trend, what we are seeing is that the degree of those increases over time are actually going down. In 2021, the median price increase was down to 4.8%, which was the lowest amount in a decade. And when you take all of those price increases that occurred in 2021 and before that, and you weight them against typical Medicaid drug utilization trends, so actually weighting it based on the degree with which we as patients take the drugs, the weighted average price increase was down to 5.3%, which was also the lowest amount in a decade. But those are just the list prices of the medications. Brand drug manufacturers offer big rebates and discounts to insurance companies and pharmacy benefit managers, or PBMs, as we discussed at the beginning, in exchange for preferential formulary placement, meaning that the insurance company and PBM are more likely to favor that drug when it comes to covering it on behalf of the patients that they represent. Now, if that sounds like I'm talking about a kickback, you would not be totally incorrect. PBMs and insurance companies have a special exemption to the anti-kickback statute at the federal level that allows for drug makers to pass through certain degrees of compensation or certain types of compensation in exchange for PBMs and insurance companies to cover those medications on our behalf as consumers. However, federal officials have rightfully questioned the utility of rebates due to the likelihood that manufacturers just raise their prices in order to accommodate larger rebate kickbacks and concessions back to the PBMs in exchange for coverage in the first place. The truth is that while list prices are going up on an annual basis, the rate at which those list prices are increasing are actually being outpaced by the degree of discounts that are being cut off the top. Let me reiterate that. What I'm telling you is that the list prices of prescription drugs are going up at a 4.3% rate as of 2021, but the changes in net prices are actually going down at a more significant clip, which means that by many accounts, the true net prices after the discounts are tabulated in many regards are actually going down over time. Now, this stuff is really complicated because it's hard to determine whether or not the true brand drug costs are going down or up over time. Because regardless of whether a drug maker is giving bigger and bigger discounts back to the insurance companies, PBMs, and government programs, we as consumers aren't necessarily entitled to those benefits or those discounts when we pay at the pharmacy counter. So because brand drug manufacturer rebates to PBMs, insurers, and companies known as rebate aggregators are confidential and vary widely from plan to plan, program to program, it's extremely difficult to pin down the true net price that is being paid for a pharmaceutical. Now, let's not just blame insurance companies and PBMs solely, because government programs like the Department of Veterans Affairs and Departments of Medicaid command such large rebates. Small payers, employers, and patients who pay out of pocket end up picking up a disproportionate share of the overall cost of a medicine. And because each health plan and PBM promote utilization of different drug mixes, making apples to apples comparisons of overall net costs is extremely difficult. Regardless of whether any of this is good or bad, this inability to objectively determine what a fair price should be hinders the ability for true market forces to pressure drug supply chain margins and promote quality and efficient spend on prescription drugs. And that's because all the prices are essentially fake. Our entire drug supply chain is built on fake prices. The list prices for prescription drugs are wildly overinflated relative to their real cost. PBMs use those list prices, the average wholesale price or AWP, as the basis for their pricing guarantees, both when compensating pharmacies and when billing plan sponsors. Brand name drugs have high AWPs or list prices that are offset by negotiated rebates and discounts that end up making the net price much lower. Generic drugs also have high AWPs and list prices that are derived from brand name drugs that in no way reflect the actual prices that pharmacies pay to acquire those drugs. In both regards, the real prices of both brand and generic drugs are completely hidden from the plan sponsor and the patient. Let's talk about the fallout of these fake prices. Anytime that somebody gets a best price, that means everybody else is getting a worse price. And that means you have a system that is solely predicated upon the practice of price discrimination. And price discrimination, it sounds bad, but it actually is quite common in markets where somebody who is selling a good or a service charges a customer a different price for that product based on what they think they can get the seller to agree to. In the context of a drug maker might have a list price of $100, but after all the discounts that they offer in the marketplace are tabulated, maybe they only end up bringing in $50 on that drug that has a $100 list price. And everybody who's purchasing that drug may be exposed to a different degree of that overall $100 rate. So we have that hypothetical $100 drug here off to the right. And as I mentioned before, Medicaid programs are required to get the best discounts in the marketplace. So a Medicaid program will pay the lowest amount off of that $100 list price. A Big Four, so the federal supply schedule, they might get a slightly worse deal than Medicaid. A Part D plan sponsor, slightly worse deal than them. A large employer, slightly worse deal than them. And then a small employer or a patient that is paying cash or they're in a high deductible health plan, they might be exposed to the greatest share or the entirety of the overall list price of that medication. Now, regardless of whether any of this is okay, and I would argue that it is not, these hidden rebates and this artificial pricing, the sliding scale pricing, is the key enabler that allows the drug supply chain to capture the benefits of price discrimination. So the question is, where are all the savings for large and small, or for mid-sized and small employers? We had the opportunity to work with a group of small self-insured employers and analyze all of their prescription drug spend and compare it to what the best commercially available prices were, at least according to the federal supply schedule. This group of small self-insured employers spent $110 million on brand name drugs in 2018. On that spend, we identified only $5 million that they realized in rebates and price concessions from their PBMs. If we took all of their drug utilization, every drug that they bought in that year of 2018, and overlaid that with the federal supply schedule, which is supposed to be getting the best commercially available price, this group of small employers would have actually realized $30 million in rebates instead of the paltry $5 million that they were able to yield. In a world free of price discrimination, where all employers received a best commercially available price, this group's rebates would have been 6 times higher. Now, bear in mind, the PBMs have already negotiated these concessions with the drug makers. So they already have received these discounts. They just chose not to pass it through to the employers that they were representing. But just before you think, hey, all we have to do is make the PBMs flow through all the discounts or get rid of the discounts altogether. Well, once you start nitpicking on what rebates are, PBMs and insurers start redefining what they are. So what we're seeing is that over time, as there's been more and more scrutiny on the rebates that drug makers pass along to PBMs and insurance companies, PBMs have reacted by saying, well, there's certain types of compensation that we get as PBMs from drug makers that we're going to start relabeling as something other than a rebate. So we're happy to show you what the rebates are, so long as we get to define all the money that we get from drug makers to say this is a rebate and everything else is something else. And that's because rebates in a formal context are whatever the PBMs and insurance companies say they are. So as they've started to recategorize these rebates as something else, essentially administrative fees, et cetera, what they've also been doing is hatching up new business lines called group purchasing organizations or rebate aggregators that live above the PBMs that have taken over the direct negotiations with the drug maker. So if I'm a PBM and my overarching enterprise owns a rebate aggregator or a GPO, myself as the PBM can comply with all the new regulatory requirements or contractual requirements around rebate pass-through. However, that doesn't necessarily apply to my subsidiary company that lives over top of me that has now taken over the direct rebate negotiations and is able to skim those rebates off the top before they pass them back through to the PBM. So we're seeing new ways that they're using clever Tetris to make sure that these big concessions that are coming in from drug makers are being able to be captured somewhere within their overall insurer PBM pharmacy enterprise. So the largest PBMs now own their own group purchasing organizations for the purposes of rebate negotiations with drug makers. CVS has Zinc, Express Scripts has Ascent, which is conveniently located in Switzerland if you'd like to go audit them. And Optum has MSR, which is also conveniently located in Ireland if you would like to go audit them as well. Now, bear in mind, they don't really negotiate rebates in those countries. That's really a very American phenomenon, but perfect headquarters for the rebate negotiating company. So they use those entities as a way to kind of hide some of those drug maker concessions and keep them within the enterprise. But then they use some of the definitions that I've put off to the side of different ways to categorize drug maker compensation by taking what used to be called a rebate and now calling it a market share incentive, a promotional allowance, commission, and all sorts of other ways that you can come up with cute ways to redefine how a drug maker pays for formulary coverage. Regardless of all these phenomenons and all the clever jujitsu that's happening, the fundamental truth remains that the higher that list prices rise, the more price concessions a PBM and insurance company can collect and retain, which is a twisted incentive for organizations who are saying that they are here to save all of us money on prescription drugs. So what's baked into these high drug prices? This is a story from Axios from last year that looked at the price of Lantus, which is a very popular insulin product. What we see is that drugs that are in competitive classes suffer the greatest disconnects between the list prices and the net prices, that post-rebate price. PBMs often still require the patient to pay the full list price while keeping the discounted rate for themselves. Lantus, for example, had a list price at the time of this article of $284 per vial. SSR Health, which is a company that analyzes discounts and rebates and makes estimates into what the true net prices are of medications, found that the actual price that Sanofi, who makes Lantus, the price that they actually receive is 13% of that overall list price. So on a drug that Sanofi charges $284 for, on average, they're only bringing in about $37 per vial. Any drug pricing reform that does not address this dysfunctional system omits one of the primary mechanisms that inflates the prices of medications. So that's everything that we talk typically about on the from the drug maker side to the PBM side. But recognize that PBMs also interact with local pharmacies. Here's how PBM behavior impacts the pharmacy marketplace. Because the prices are all predicated off of these pumped up, artificially inflated list prices, what you have is that you have twisted incentives. As I mentioned at the beginning, PBMs are not just PBMs. They have their own rebate aggregating companies or GPOs. They also make money off of pharmacy. the largest PBMs own their own specialty pharmacies. They own their own mail order pharmacies. In the case of CVS Caremark, you might recognize CVS Pharmacies. Caremark being the PBM, CVS being the pharmacy. Well, in the state of Florida, we did a public records request where we got 350 million claims worth of data in their Medicaid managed care program, when we were able to see on a drug by drug, day by day, plan by plan, PBM by PBM, and pharmacy by pharmacy basis, what the reported cost was to the state on every single product dispensed in the program. What we found was that when PBM-owned pharmacies were dispensing the products, the state of Florida was getting a worse deal on all of those medications. So we looked at brand name drugs, and we looked at every brand name drug that was cheap, every brand name drug that was cheaper than $2,000 a claim versus every brand name drug that was over $2,000 a claim. And what we found was that PBM-owned pharmacies dispensed a small fraction of the cheap brand name medications. However, when the drugs were very expensive, the PBM-owned pharmacies filled a disproportionate share of all of those claims relative to the competitor pharmacies in the marketplace. Now, if PBMs are here to save us money, as they advertise, it would be obvious that with their size and scale, given these biggest PBMs are Fortune 15 companies, that they must be able to get the best discounts in the marketplace because of what we know from Economics 101, that big leverage and big scale should yield big concessions in a market. That's not the case. For the 4 largest plans in the state Medicaid program in Florida, we found that when PBM-owned pharmacies dispensed the products, it was more expensive for the state versus when they were dispensed at traditional community pharmacies that had no ownership or business relationship with the PBMs themselves. Now that's an aggregate look, but let's look at just one drug, where the pharmacy service should be materially the same from pharmacy to pharmacy, and the cost of the drug should be materially the same from pharmacy to pharmacy. This is one of the most expensive and controversially priced drugs in the marketplace. I'm sure you've heard people complain about it before. The Humira, which is a very expensive brand name medication. In the Florida Medicaid Managed Care Program, 80% of all the prescriptions for Humira were filled at pharmacies that were owned or affiliated with the PBM. Just under 20% of those medications were filled by pharmacies that did not have direct business ties to a PBM. And yet again, for the largest plans in the state Medicaid Managed Care Program in Florida, the state got a worse deal on the product when it was dispensed at a PBM-owned pharmacy versus when it was dispensed at a non-affiliated pharmacy. If Florida Medicaid would have said the PBM-owned pharmacies can't fill any of these claims, and they can only be filled at traditional mom and pop pharmacies or local chain pharmacies and grocery store pharmacies that weren't owned by PBMs, the state would have saved $1.5 million in savings on just Humira alone in 2018 and 2019. Those are the brand drugs, though. Let's look at the generics. As I mentioned before, in the US, every drug has multiple different prices. AWP, average wholesale price, and wholesale acquisition cost, WAC, are both unilaterally set or derived from the manufacturer setting the price. They are not dictated by competitive market forces. It is a sticker price. However, there are other benchmarks like national average drug acquisition cost, or the state of Alabama, which has their own pharmacy acquisition cost survey, where pharmacies who are out there buying drugs out in the open marketplace in a competitive fashion report the prices that they acquired those drugs back to CMS, or in the case of Alabama, back to their Medicaid program. And with those benchmarks, you can see what the real prices are, an approximate price for what pharmacies pay to actually stock the drugs and put them on their shelves. My home state of Ohio is pursuing that type of model as we speak. But as you can see, there's a big difference between the sticker price of a medication and the actual price. Here we have generic Nexium. The AWP in June of 2020 for generic Nexium was just under $800 for a 90-count bottle, 47 times higher than the average prices paid by Alabama pharmacies to acquire that drug at the exact same time. So there's a huge disconnect between the list price and the real price of generic drugs. That gap that exists between there is all opportunity for members of the drug supply chain to make money in between those numbers. That brings us to how I got started studying drug prices like a dork. Our state of Ohio Medicaid program revealed $244 million in spread pricing between the second quarter of 2017 and the first quarter of 2018. So what is spread pricing? In Ohio, pharmacies were complaining to me when I was still working at the Ohio Pharmacists Association that they were suffering from massive underpayments in our Medicaid managed care program. I went back to state officials, Governor Kasich's administration at the time, and asked them, what's going on? Did I miss a policy change? Why are pharmacies seeing a 60 to 80% cut in the gross margin on the prescriptions dispensed in the Medicaid program? What is going on? They looked at me like I was crazy because they said they had never been paying more for prescription drugs than they were at the time. What we discovered was that PBMs were taking advantage of the non-transparent way with which they were able to manufacture and set prices in the program by paying pharmacies very low for the products that were dispensed, but then turning around to the state and pumping up the receipt that they sent back to them when the state was cutting the checks to the managed care plans. So they were paying low, billing high, and pocketing the difference, and not disclosing this massive amount of money that was living in the middle of the transaction. Our state auditor at the time, Dave Yost, did an audit and found that the PBMs were taking fees of 31% on all generic drugs in the program. Overall, between all the brand name drugs and generic drugs, PBMs were taking $244 million in hidden money in between what they paid pharmacies and billed the state. Fast forward the tape, after years of investigation, years of controversy, the state fired the PBMs and are in the process of moving to a fully transparent single PBM model in the Medicaid program. Former auditor Dave Yost was promoted by voters to attorney general and is now suing PBMs over alleged fraud, waste, and abuse issues in our Bureau of Workers' Comp program, our Medicaid program, and in our state highway patrol fund. One of the Medicaid managed care plans who own their own PBM is a company called Centene, a very large insurance company that does a lot of work within state Medicaid programs and state prison systems. They found that under the Centene plan, the spreads were over $11 per prescription under the plan. Yost sued them for alleging fraud, waste, and abuse. Centene denied any wrongdoing. However, they did send Attorney General Yost an apology note and $88 million to settle the litigation, and have also settled litigation in Mississippi for $55 million and have set aside more than $1.1 billion to settle alleged issues with the same type of practices in other states across the country. If you've never heard about this, it's understandable. This is the first and largest settlement in the country secured by a state attorney general against a PBM. And Ohio isn't alone. My firm did an analysis in the state of Michigan, where 450 pharmacies across the state voluntarily submitted all of their drug product reimbursement data to us, and we analyzed it against the aggregate data that the state reported back to CMS to see what the state was being charged on pharmaceuticals and compare that to what the pharmacies were actually paid. Now, what you see, if you could burn a chart into your brain, this would be one of them. The blue line represents the average cost that pharmacies paid to acquire medications within the Michigan Medicaid managed care program. The green line represents what the 450 pharmacies that we analyzed were actually paid on those prescriptions. The orange line represents what the Medicaid managed care plans, through their PBMs, reported back to the state as the cost of those medications overall. As you can see, the cost of the drugs are going down. The payments and the margins to the pharmacy are going down, except the PBM spread, the difference between the orange line and the green line, are going up exponentially over time. Unsurprisingly, when we're talking about hundreds of millions of dollars in state budgets, a lot of people are upset. Many states have outlawed the practice of spread pricing in their Medicaid programs. CMS has issued new guidance actually requiring significant degrees of transparency with spread pricing. And there's been a push at the federal level, bipartisan, Republicans and Democrats, to kill spread pricing in Medicaid programs and even to extrapolate it into the commercial marketplaces as well. We're even seeing some nonprofit regional health plans pull the plug on PBMs subjectively setting prices in a marketplace that they have an obvious conflict of interest in. So more and more is happening where we're seeing change start to occur in the marketplace. However, just when you think you have the answers, the PBMs and the drug supply chain as a whole start changing the questions. So if you thought that you could solve these problems by getting rid of how PBMs make money off rebates, if you thought that you could get rid of these problems by just banning spread pricing, I have news for you that the PBM focus from a profitability standpoint on those two line items have actually been in a state of decline and erosion over the last 7 years. What you see here is that as the proportionality with which PBMs make money off spread and rebates have been going down over time, it's given way for profits that PBMs generate off of loosely defined administrative fees and the money that they make from dispensing medications through the specialty pharmacies that they own. I was involved with a recent analysis that was conducted by the PBM Accountability Project nationally, where we actually did surveys and analyzed public filings of PBMs to analyze how they made their money. And as you can see over time, their profits have increased into the billions over the last 3 years. But not only, it's not, of course, their profits are going up. These are big companies and we're in a period of significant growth. What we're seeing is that the way that they're making money is changing over time as well. Well, if there's another chart that you could burn into your brain, this is another one. This is from the state of Florida. Again, we could see granular level data of what the reported costs were on a drug by drug, pharmacy by pharmacy basis. We were able to see how CVS Caremark pricing patterns changed when they were able to take over the book of business for the Centene plan in the Florida Medicaid program. CVS Caremark started taking over pharmacy pricing in the middle of 2017 in Florida Medicaid managed care under the Centene plan. The chart here shows you the pricing patterns that reported to the Florida Medicaid program on the number one spend generic antipsychotic medication. This is generic Abilify. And as you can see, the reported data from the state of Florida that covered the Centene plan showed that the second that the CVS Caremark took over the price setting within that plan, payments to independent pharmacies is represented by the orange line, and payments to Publix pharmacies is represented by the green line, fell through the floor, while simultaneously the payments reported at CVS pharmacies shot through the roof. It is a clear conflict of interest that CVS Caremark, the PBM, has the subjective ability to set the prices of their competitors as well as the pharmacies that are owned and operated by their overall enterprise. Not only do PBMs engage in differential pricing, but we also find the steering problems and the overpricing problems that we had identified on the brand side are also manifesting themselves over on the generic side as well. Remember that we saw that a small share of the cheap branding medications were being filled by PBM-owned pharmacies, but when you got to the expensive ones, they were disproportionately filled at PBM-owned pharmacies, and they were done so at a more expensive rate for the plan sponsor. That exact same dynamic is occurring in the commercial marketplace with generic products as well, where PBM-owned pharmacies are filling a very small share of the cheap ones. They're filling a very large share of the expensive ones. And when doing so, they're doing so at an extremely handsome markup when paying the pharmacies that they own. The Florida Medicaid program, after we did our analysis, did some, what I would say, certain validations of some of the things that we found in our report. But as you can see here, when analyzing the margins that PBM-owned pharmacies make, specifically in the specialty category, and you compare that to the average margin per prescription the traditional pharmacies are filling, Publix, Walgreens, Walmart, CVS, Independence, and Winn-Dixie, as you can see, PBM-owned specialty pharmacies are making a significant amount of more profit per prescription on brand name drugs than when you compare the profits or margins that traditional pharmacies are making when they are not necessarily owned and operated by the PBM. This is not just a small pharmacy problem. This is a problem that impacts Walgreens as well. Bear in mind, CVS and Walgreens have very similar market presence within the United States at a pharmacy level. The main difference between the companies as a whole is that CVS owns a large PBM and Walgreens does not. This is an audit. Analysis that was conducted by the state of Florida. This is not our work. This was done by Milliman, a firm working on behalf of the Florida Medicaid program. Just to give you an idea of how advantageous it is to own a PBM when you're a pharmacy company. The number of pharmacies in the state of Florida between Walgreens and CVS is not materially different. They are within just a few locations of one another. They have about the same footprint within the state of Florida. The main difference between them is that CVS Pharmacy has a PBM that's owned by their enterprise that can tell patients where they can and can't get their medications filled. Walgreens does not have that luxury. Despite having essentially that exact same footprint in the state of Florida, over the same time period when filling prescriptions for Medicaid patients in Florida, Walgreens filled just under 2 million prescriptions, while CVS filled just under 11 million prescriptions, despite having essentially the exact same market presence in the state. In Ohio, after the state banned spread pricing, just as a reminder, spread pricing is when the PBM pays the pharmacy low, they bill the plan sponsor high, and they pocket the difference. After the state banned PBMs from doing that, pharmacies across the state started seeing an increase in reimbursement on a specific number of products that they dispense to patients in the Medicaid program. Drugs like generic Gleevec, which is meant to treat leukemia, pharmacies that were dispensing that product saw a 1,762% increase in markup between when the state had spread pricing in place versus when it was banned. What we found was that as the state told PBMs they couldn't make money via the gap between what they pay pharmacies and what they bill, PBMs responded by taking that money and flowing it down to the pharmacy level, but doing it in a way that disproportionately favored medications that were more typically dispensed by pharmacies owned by the PBM. So some pharmacies across the state were singing praises, saying, wow, this is so great. We're making so much more money now that we got rid of spread pricing. Little did they know that they were just getting a few crumbs off the table, while the PBM-owned pharmacies who were dispensing a lion's share of these overpriced medications were helping themselves to the buffet. These problems continue to persist in Ohio today, but they are by no means unique to Ohio and by no means unique to Medicaid programs. Lastly, what about Medicare Part D? As Congress debates Medicare drug negotiations with drug makers, data on the ground shows massive disconnects in what seniors pay within the Medicare Part D program. This chart is from our 46 Brooklyn Medicare drug pricing ski slope. It's available. You could take a look at this data on your own on our website. The average price for generic Gleevec in the first quarter of 2019 was just under $15 per pill. This chart off to the right is a ski slope chart. Every little line that lives on this chart represents the reported price of the drug at a specific Medicare Part D plan. So we've got hundreds of Part D plans reflected on this chart. And as you can see, the prices from plan to plan vary wildly from plan to plan. Despite this product being just under $15 per pill in the first quarter of 2019, we found that the lowest Medicare Part D plan off to the right of the chart had this drug priced at just under $10 per pill, a very competitive price, very good price. However, the average price under the Part D plans was at $153 per pill. The highest plan price was at $315 per pill. Now, bear in mind, this is a product that a patient will be on for the rest of their lives. They will take it every single day. If we care about high drug prices for seniors, how can this type of disconnect when a $15 pill is being charged to a senior at $315 per pill. How can we not address those type of distortions? Lastly, this is a report that we put out just before the close of the year. What we did is we did an analysis looking at Medicare Part D formulary design to see what plans were doing when cheap generic versions of particular products entered the market. We looked specifically at the popular multiple sclerosis medication Tecfidera. In the third quarter of 2021, the list price of brand name Tecfidera was $8,275 per month. The generic acquisition cost for that product at the time was $184 per month. So we're talking about a massive, massive difference between the brand price of Tecfidera and the generic. What we found was that even though the generic was significantly cheaper, more than half of the seniors in Medicare Part D were enrolled in plans where their PBM and insurance company forced them to buy the brand product and didn't even allow them access to the generic medication, despite the fact that it was more than $8,000 more expensive per month. So I'll leave you with this. This is a chart looking at stock performance of particular market segments within the drug channel. I say this not to say, hey, drug makers aren't the problem, pharmacies aren't the problem. I'm here to show you this because the only members of the drug supply chain who are advertising that they're here to lower prices and costs are managed care plans and PBMs. The green line here represents the median list price per 30 count brand name prescription over time. And as you can see, as the list prices of medication on average increased significantly starting in 2006, the stock performance of managed care plans and PBMs far dwarfed that of manufacturers and pharmacies that were operating in the marketplace over the same time period. Now, obviously, this is an unfair analysis in many ways. Managed care plans and PBMs do a lot more than manage just rebates and work with list prices of medications. But I say this because the era of high drug prices has benefited nobody more than managed care plans and PBMs over that time period. And to me, it begs a very serious question, whether or not the entities who say they're here to save us money have adequate incentives to do so in the first place. So a few strategies for reining in PBMs. Some states are moving to carve out pharmacy benefits or move to a single PBM. They're moving towards pass-through pricing and full transparency. They're prohibiting things like patient steering when a PBM tells a patient they have to use a pharmacy owned by the PBM. We're seeing bans on spread pricing, gag clauses, and copay clawbacks. We're seeing more legislation introduced at a state level requiring PBMs to share the savings, pushing all those drug maker rebates back to the patients and the plan sponsors. We're seeing reverse auctions, innovative contracting strategies that forces PBMs to compete in ways they never had to in the past. We're seeing bans on things like copay accumulators, and we're even seeing some folks take a hard look at imposing fiduciary obligations upon PBMs in the market. With that, I probably talked way more than Rebecca wanted me to. I thank you for stomaching the presentation, and I'm happy to answer any questions that anyone might have.
Sorry about that. Hold on just one second while I try to figure this out. So we do, I'm going to challenge everybody. If you didn't learn a lot, I'm going to be surprised. I, for one, cannot tell you how much I learned. That was fantastic. Thank you so much for that. First of all, I have to get it out of the way. Are you still on a high from the Rose Bowl?
Honestly, I'm a little spoiled as an Ohio State fan. If we're not playing for the national championship, it's not really all that exciting.
Okay, so I did not have college football where I went to school. I follow my husband's team. We're never going to be there, so it's fine. I'm a WVU fan. It's just never going to happen for us. So anytime you get that close, it's a big deal for me. It was a great game though. We have so many questions from so many places. That was fantastic. I'm going to start with what we have at Zoom. Where do things like GoodRx come into play here? And this was asked a few times when we're talking about rebates. So you talked about the anti-kickback concessions. Is GoodRx and things like that associated with that kind of program?
So GoodRx is a very unique entrant into the marketplace, one that is born out of dysfunction. And I've said this many times. GoodRx shouldn't exist, and I don't mean that because that they're bad or rotten. They are putting out a fire that shouldn't exist in the first place. Medications in the United States are dysfunctionally overpriced relative to anywhere else. And now, granted, some of the other countries have their own problems, and one would argue that maybe perhaps some of the price controls that are in those countries are dysfunctional in different ways. But for the sake of this discussion, medications in the United States are wildly overinflated, and GoodRx basically exists to say they don't have to be so overinflated, and they act as a Band-Aid on a broken marketplace. Granted, GoodRx creates its own complications and distortions into the marketplace, but GoodRx essentially exists to make sure that pharmacies who are incentivized to have higher sticker prices on their medications, GoodRx exists to make sure that a patient who has no insurance is able to get some level of discount off of those artificially inflated prices. And it's very complicated. I'd be happy to go into it further, but I think we'd have to spend another hour talking about some of the dysfunction on the pharmacy pricing side.
Yeah. When you're talking about price discrimination, how do we get rid? What are the steps to get rid of that? Because we talked about, you talked about a lot of the steps some of the states are taking where things are on the federal level. What are the steps being taken to get, just starting with price discrimination and then moving forward? I think, that was kind of the basis for what you started talking about.
So the system is inherently going to be compromised in that the price is always negotiable. And I hate saying that because negotiation is a cornerstone of a market-based system in many ways. But we're talking about a marketplace that has gotten totally out of control and highly distorted by government's influence over the discounts that are achieved in the marketplace. I want drug makers to compete on price. They compete now on kickback. They compete on discount. And so there's this is not a typical marketplace in that this is one of the only places in the United States and the only marketplaces that have that exemption from that anti-kickback statute. The Trump administration had proposed eliminating that exemption, and it has since been delayed and walked back by the Biden administration. I don't know how much conviction the Trump administration really had in getting that across the goal line, but that would have been a good start to say, look, the drug maker price needs to be responsive to competitive market forces, not the discounts and concessions that are being gobbled up by middlemen.
So in talking about, one of the questions was, when you were talking about pricing at the beginning and the difference between the years and the pricing and how, pricing has gone up, pricing has gone down. Was that adjusted for inflation, or are we seeing, because we do have a kind of a spread of the years there?
Yeah, the charts that I had in the beginning of that are apples to apples. So there's no adjustments for inflation. Usually list price increases exceed rates of inflation. This past year, I believe, is the first one that was off that trajectory. I think drug prices are actually beating the current rates of inflation that we're seeing in the marketplace.
Okay, so I'm going to read this out. HHS OIG has issued a ruling which supposedly will eliminate the safe harbor protection for rebates afforded to PBMs by drug manufacturers. This is due to take effect in January 23. How do you think this will actually play out? Will it truly eliminate the safe harbor exemption? Will it provide for transparency with regards to what PBMs are doing in regards to PBM contracts? That's a great question.
So I think that that it was going to act as a very good purification of that market, and that eliminating that that exemption was going to be something that was really very healthy. One of the arguments against getting rid of the rebates and the kickbacks was that insurance companies argued, and others argued, that insurance premiums would go up if they eliminated those items. So there's been a lot of political squeamishness around eliminating it because the fear of insurance premiums go up. But I want to say this: I don't know if that's actually true, that premiums would go up if you got rid of the rebates. The argument that insurers and PBMs make is that we get these big discounts from drug makers. We pass some of them or all of them through as a means to lower premiums for all of our beneficiaries. If you agree with that, and I think I can nitpick over that, I actually disagree with that statement. But let's just say if you agree with it, what that means is that you're okay with drug prices being artificially inflated as long as it's lowering premiums for everybody. And that's another way of saying that the sick are subsidizing everybody because the sick are having to pay higher prices for medications than they should. And we're willing to stomach that because it's generating big discounts that we could give to everybody in the form of lower premiums. That is the opposite of insurance. So to me, that's an inherently broken system, and one that needs to be turned upside down, because the idea of health insurance in the first place was to help you when you had an unexpected cost, not to hurt you disproportionately when you do.
You talked about, obviously, the CVS Caremarks, the big pharmacies that have their own PBMs. We talk a lot about independent hospitals that are going out of business and what that looks like right now. What about what are things like PBMs, and do you have the information with the advent of PBMs? What is this doing to independent pharmacies? Do you know?
So, all community pharmacies that don't have their own interests in a PBM are at an inherent disadvantage. Because as I pointed out, one of the inherent conflicts in this system now is that we tend to look at providers as price takers. All right, whether you're a physician, whether you're a clinic, whether you're a pharmacy, big pharmacy, little pharmacy, you are relying primarily on insurance as compensation. All right. Now, obviously, there are cash only, physician practices, cash only pharmacies, that all exists. But the patient population expects coverage, all right, through these traditional insurance forms, which have their own problems, be clear. But for the sake of this discussion, that most providers rely on insurance companies, and in the case of pharmacy, PBMs, as their primary form of compensation for serving patients. Here you have CVS Caremark. Caremark is a PBM that is both a price taker and a price setter. So they have the ability to subjectively set the rates, overpay on certain drugs, underpay on certain drugs, engage in discriminatory pricing if they want to, pay their own pharmacies more than they pay their competitors. All of those things are completely allowed, and somehow able to skirt past, FTC scrutiny, or FTC ruling. They are the largest PBM in the marketplace, and they're able to control the prices for themselves and their competitors. That obviously is going to have a very drastic impact on not just independent pharmacies. Arguably, it's most exacerbated with them, but it impacts everybody from the independent all the way up to a Walgreens.
Okay. I'm going to take two more. So you talked about spread pricing, and that was really interesting for me. It was great information. In one of your charts, one of your slides rather, you talk a lot about what the states are doing individually. But one of your slides rather, there was something you spoke briefly about what they're doing on the federal level. And, state by state, oftentimes that's where the work is going to be, and that's great. And CMS has issued a ruling trying to narrow it down. You mentioned that there's some movement on the federal level, but the last thing that you put up, it was something, by Grassley in 2019. Where are we now?
So a great question. Grassley and Wyden had a proposal on the table to ban spread pricing. And that was when Grassley was still chair of finance. Now, obviously, the roles have shifted. Wyden is captain of the ship. Wyden has talked a lot about trying to go after PBMs, but as of right now, I have not seen a spread pricing ban in any of the Build Back Better stuff or any of the infrastructure stuff. We've, I know that it's been debated and they've said it's a priority. The proof is in the pudding, right? Right now the text doesn't exist in anything that is viable. So right now, I don't see anything from a federal perspective that is aiming to address it. Now, Republicans held a special hearing in November that I got to participate in the House, and they brought this up, and they were, really interested in going after some of the spread pricing stuff, spread pricing issues, and the rebate issues. But obviously, they're in the minority now. Their power is going to be limited. So now, granted, when they had the power, they didn't do anything about it either. So, I'm not sure what will happen at the federal level. I'll just keep drinking from the glass of pessimism.
I always ask this question, and this is what I'll end with. We try to create advocates. So if a medical student decides to advocate, and however that becomes, for themselves, as well as the other attendees here who might not be physicians, or physicians themselves if they're here, what can they do? Or myself as a consumer, what can we do to be advocates for proper pricing for our pharmacies? What can we do?
So, for anybody that's in the healthcare, I mean, look, this isn't true for anybody, but if you're entering the healthcare field, you're doing it because you want to serve patients, hopefully so. And your charges to that patient. What's the best thing you could do for that patient from an advocacy perspective is making sure they're not stuck in a system that exploits them. And I believe it's incumbent upon all pharmacists, nurses, physicians, you name it, to have a better understanding of how the system works and speak up about the collateral damage that it creates. Not just from, I came from the pharmacy world, and the pharmacists, they definitely cared about the patients, but I also saw very much of how this impacts me as a provider. And granted, that's very important, and it shouldn't be discounted. But we need to fix the system, not because we need it better aligned for any one particular entity. We all deserve a better system, and we deserve to have members of the drug supply chain and outside of pharmacy, all the healthcare delivery system, to have the right incentives to do the things that we actually want them to do. One of the things that I like to talk about is that, look, it's not that PBM shouldn't make money. It's not that wholesalers should make money. It shouldn't be that drug makers, everybody should be entitled to compensation relative to their value proposition, but they shouldn't be entitled to a compensation that's purely derived from arbitrage and smoke and mirrors and artificially inflating costs. So one way that you could advocate, I think, is to demand greater transparency in the system, because all the money is being made underneath the covers. And so we need to pull the covers off. We need to have a better understanding of where providers or any member of the drug supply chain, from the end of the spectrum to the beginning of the spectrum and everywhere in the middle, is either over-incentivized or under-incentivized to do what it is we want them to do. We will not diagnose those problems unless we have a lot more transparency than we currently have today.
Great answer. Transparency. We talk about that a lot. I appreciate your dorkiness. That was fantastic. That was so much fantastic information that I think many people are already emailing and texting me asking for a copy of this recording, and it will be up on our YouTube, and I'll send it out. I thank you. I thank you for this fantastic tutorial, but just download of this information, because I don't know another place where we can get all of this. So Antonio, thank you. Happy New Year, by the way. To everyone out there, I'll send as a follow-up the information provided here today. I'll send you a link to our YouTube channel, and as well as when we do put this recording up, I'll send it out to you as well. If you do have any more questions, I will show you how to get in touch with Antonio, but also with myself. If you're a medical student, let me know, and we will get in touch with you as well. Go to benjaminrushinstitute.org, sign up for our newsletter, and you will be notified about when we have our next webinars. We will be rescheduling Dr. Paula Muto, who we were supposed to have last month, and we rescheduled by fault. I'm looking forward to hearing more questions. Thank you so much, and we will talk to you all soon.